was 28-year-old female, housewife 12th standard, came from Katumanar Koil, right-handed person, and informant was self and father. Patient chief complaint was imbalance while walking for past 9 years and involuntary movements of both the hand and head for past 5 years and involuntary micturition for past 1 year. In history of presenting illness, patient was apparently normal 9 years before, after which during the 4th month of postpartum period, she noticed the complaints of unsteadiness of gait, which is insidious in onset. Unsteadiness noticed initially while turning, later she developed unsteadiness even while walking and standing. Swaying was present all over the body without lateralization. Initially, patient was able to walk and travel outside with the minimal support for past 1 year, and she gave the history of improvement of symptoms over the next 3 years, able to walk without support. And then she remained static over the next 1 year. Then the symptoms was worsened and gradually progressive over the next 4 years. Patient able to do only daily activities with the holding of walls. Then unsteadiness aggravated a narrow pathway and it's not increase on closing of eyes and darkness. And unsteadiness not associated with the loss of consciousness, giddiness, tinnitus, ear pain, ear discharge, vertigo, and slurring of speech, weakness of the limbs, and frequent fall. Then associated with the clumsiness were present in both the upper limbs. While trying to mix foods, there is a spillage of food around the plate, and she could bring food to her mouth, but there is a history of stubborning of food over the face. Associated with the tremors involving both the upper limb, which was symmetrical in nature, insidious in onset, and gradually progressed to head at present. The tremors aggravated on doing activities and relieved by rest. And history of urinary incontinence for past 1 year in the form of increased urinary frequency, urgency, nocturia, and incomplete bladder evacuation after voiding, and history of able to perceive bladder fullness, no history of any interrupted stream of urine, dribbling of urine, no history of hesitancy, and history of constipation was present. The patient able to feel the fullness of a bowel and able to initiate and complete evacuation of the bowel was present. Then patient history of difficulty in combing the hair and holding the object was present in the form of clumsiness and tremor due to clumsiness and tremor, and history of difficulty in buttoning and unbuttoning the shirts was present due to tremor, and history of difficulty in using the Indian toilet in the form of swaying, and history of difficulty in climbing stairs up and down in the form of swaying. No history of difficulty in raising arm above the head, and no history of difficulty in getting up from the chair. The history of difficulty in guiding of slippers was present, but no history of difficulty in slippage of slippers, dipping of slippers, and no history of loosening and shifting of the limbs, and no history of difficulty in lifting the head off the pillows, and no history of difficulty in rolling over the bed and getting up from the bed, and no history of buckling attacks, and no history of wasting, thinning, and fatigue and muscle twitching was present. And patient able to feel the clots and feeling hot and cold water while bathing, and no history of electrical shock-like sensation while flexing the neck, no history of numbness and pin and needle sensation, cotton wool, no history of root pain, neck pain, back pain, no history of bandle-like sensation, grid-like sensation, and no history of any disturbance in smell, no history of blood vision or transient loss of vision while patient exposed to hot shower or any elevated body temperature. Patient able to see the distant and near object, able to appreciate and distinguish the color, no history of double vision and no history of drooling of eyelids, and no history of difficulty in appreciating the sensation over the face, and no history of deviation of angle of mouth, drooling of saliva, no history of hard of hearing, tinnitus, vertigo, and no history of hoarseness of voice, nasal speech and nasal regurgitation. There is no history of difficulty in turning the head from side to side and shunting of shoulders, able to roll tongue and push food on both sides. Then no history of fever, seizure, altered sensorium, neck rigidity, and no history of vaccination, viral infection, any drug intake, no history of cough with expectoration, chest pain, breathlessness, and no history of loss of weight, abdominal pain, loose stools. Patient past history, not a known case of type 2 DM, CAD, hypertension, CKD, and thyroid disease. Birth history, patient was second born and non-consanguineous marriage and was normally vaginal delivery delivered at the hospital, and she cried immediately after birth, and history of breastfeeding up to the age of 8 months. She was vaccinated approximately as per the national immunization schedule. Then personal history, mixed diet, normal sleep and normal appetite, history of urinary incontinence present, history of constipation present, no history of addiction. Family history, there is no significant family history. Menstruation history, patient normal flow and regular cycle, 4 days per cycle, changes 2 pads per day and no clots. Treatment history, tablet dimethyl fumarate 240 mg taking BD and tablet mirabegron sulfasalazine taking 25 bar 5 mg, OD for past 2 years. Then summary of the patient, 28-year-old female patient with no known comorbidities with no significant family history during her 4 months of postpartum period came with the complaints of insidious onset CNS manifestation in the form of acting and manic symmetrical gait ataxia associated with the tremors involving both the hands and feet with the bowel and bladder involvement without cranial and sensory involvement. Success involved mostly vermis anterior part of the paleocerebellum and cerebellar hemisphere neocerebellum. A possible etiology because of acting and manning symmetrical gait, demyelinating or any nutritional. My differential diagnosis was relapsing limiting multiple sclerosis and vitamin E and vitamin B12 deficiency.
Okay. We'll start your history.
Okay.
First you told the right-handed person, no?
Yes, ma'am.
Did you decide her handedness?
By pinhole test and asking them to hold the hand, the dominant hand will be front and kicking the ball.
So what all methods? You said, what did you ask first? How to know right?
Pinhole test. Pinhole test, we have to see which hand and eye patient have to see by pinhole test. Then we have to ask the patient to hold the hands.
What is the application for pinhole test generally? Why do you use pinhole test? What situation do you use pinhole test?
To see
Patient has got a visual problem.
Fundus
to know whether that is due to refractory error.
Okay.
That is the situation we use pinhole test. So if it is due to refractory error, it will improve with the pinhole test. If it is due to optic nerve or retinal disease or macular disease, it will not improve with pinhole test. So pinhole test is to differentiate between other causes of visual impairment from refractory error. That is the situation. So here what all things you will do means you should check handedness. First, of course, we ask which is their dominant hand, where they were shifted at any time. That you can ask. Second, as you said, handedness goes with eyedness. So you don't check with the pinhole test. Okay. We tell the patient to focus on a tube light or focus on a letter with one eye. So which eye they will use? That is the eyedness. Normally, we tell them to reduce the radiation of light from the object of interest. We tell them to use a tube, that is, it can be an illuminoscope. But undergraduate studies, we used to use illuminoscope, no, to know transillumination and all. The X-ray tube is usually rolled and it is used to focus. Okay. So that can be used in not pinhole test. So you check eyedness by telling the patient to focus on an object, and that is usually to prevent the diversion of light. We use a illuminoscope. So handedness goes with eyedness. Then what else? You said that when you put one hand over the other, what will happen? Dominant hand will come up. Dominant down, D, no? So dominant will be down. Okay. Next, what else you will do? Ask them to kick the ball. You put the hand behind it, both hands behind, the dominant will be up. You just cling, then dominant will be down. Hold back, dominant will be up. Then which leg is the dominant leg? Right leg will be dominant. It is generally right eye, right hand, left ear, left foot. Okay. So dominant eye, dominant hand or right, dominant ear and dominant leg is left. That is why I am sure in villages, we know that people have to put a right foot and get into the house when you go for some auspicious function and all. Especially when marriages are taking place, somebody will stand on the door. I am from Tamil Nadu, there and all. If you go with the left foot first, that becomes very bad woman. So somebody will stand. Reflexively, left foot will come. Okay. To remember that, you can remember the old land phones. Okay. Which ear you use? land phone is designed for the left ear only. So left ear is the dominant ear, left foot is the dominant foot. So and right hand and right. So you will check eye-headness. First tickling, as you said, dominant down, back dominant up, then eye-headness. Then what else you will use at the bedside? You can use so many small things. You can do the EEG. You can do what is something called Edinburgh's handedness inventory. Have you heard of that? Supposing you are doing a study, Edinburgh's handedness inventory contains 10 points, 10 activities, 10 common activities, of which 8 activities should be carried out by the dominant hand. So if you are doing a research on what is the handedness of patients who present with dementia, something like that, no? Then you have to do Edinburgh's handedness inventory. That's a 10-point score. And there is an extended Edinburgh's handedness inventory containing 21 points. So 80% of the points should be with the right hand. Then it becomes a dominant or the dominant hand. That is Edinburgh's inventory. Then you can do the electroencephalogram. It is available in every medical college, everywhere it is there. So EEG will show relaxation rhythm on the non-dominant side. Normally, you have got a beta rhythm anteriorly, it's a very fast rhythm, and alpha rhythm posteriorly. So alpha is a rhythm of relaxation. So in which side you find better alpha is the non-dominant hemisphere. If it is a right hemisphere, normal right-handed people, the right hemisphere will show alpha rhythm. So better formed alpha rhythm indicates that hemisphere is relaxing. So that is the non-dominant hemisphere. Then you can do amytol test. You heard of amytol test?
No.
Inject sodium amytol. It is a phenobarbital, short-acting phenobarbital into the carotid artery, and tell the patient to keep both hands stretched and keep counting. In which carotid injection the counting stops, that area contains the language area. So that is the dominant hemisphere. And that hand will also drift accordingly. So that is called intracarotid amytol test. Then you have got functional imaging, PET scan. So these are the methods by which you find out the hemisphere dominance, which correlates with the hand dominance. Why you are concerned in neurology about handedness?
Dominant speech area. Speech area we have to, if any stroke patient will come now, then speech area we have to check for.
Speech area, that means what?
Speech.
Oh, speech area, what you have to do?
Dominant, we according to that handedness, we have to tell the dominant hemisphere is affected for speech area determination.
Speech area or language area?
Language area.
So determine language area is not done by handedness. It is by analyzing language. You see, you don't decide language area by looking at the handedness. You analyze the language of the patient. And if the patient shows features of aphasia, you know the language area is affected. It is not done by looking at the handedness. So handedness is important for so many reasons. One, all the neuropsychiatric tests. Any patient with a cognitive impairment or memory problem, you have to neuropsychiatric tests all over the world are standardized only for right-handed people. So our neuropsychological tests are not that sensitive for left-handed people because it is not standardized for left. So it is to find out the sensitivity and specificity of neuropsychological tests in patients with any cognitive impairment. Yes, all the neuropsychiatric tests are standardized only for right-handed people. Second, in tumor surgery or in epilepsy surgery, tumors infiltrate and epilepsy produce sclerosing lesions. So these lesions may not produce language problem, even though they are on the dominant side. But after you resect the epileptic focus or after you resect the tumor, patient might lose the language, then becomes a serious problem. They'll say my patient was speaking and after he operated for his epilepsy, he has become aphasic. So it is much better than having an epilepsy than become aphasic.
Okay.
So during tumor surgery or during epilepsy surgery, you have to prognosticate what is the possibility of patient losing the language so that they don't sue us after the surgery is done.
Okay.
So that is to decide this for pre-surgical evaluation. Then the third point is some patients are bidextral, ambidextrals. Their right and left hands are equally dominant. So that has got a prognostic relevance. A patient with a hemiplegia and aphasia, if he is ambidextrous, his chance of recovering language is much better because he can shift the function to the opposite perisylvian area, which is equally dominant. So co-dominant of language area, they are ambidextrous people. Then you can say even though you are a right hemiplegic and aphasic, because you are ambidextrous, your chance of recovery of language is better. So these are the reasons to know the handedness. Mostly we tell handedness in neurology because if the patient develops some cognitive dysfunction later, your neuropsychological tests are not that sensitive and specific. So that is the thing. So you have done handedness and you said she's a right-handed person. And in the postpartum period, she developed imbalance. No? So what are all the diseases which abort during pregnancy and worsen during after delivery? Can you tell some conditions?
One is multiple sclerosis. Second one is CVT, cortical vein thrombosis. Then
what I am asking, a disease which becomes low profile during pregnancy and aggravates in the postpartum period.
Demyelinating conditions was another depressed in pregnancy period and aggravated on postpartum period.
Why is it depressed in pregnancy period? There is something called immunology of pregnancy and delivery. You see, your answer is correct. There are other conditions, vasculitis, rheumatoid arthritis, migraine headaches, some epilepsies, no? For why demyelinating Behçet's disease, you see, the reason is the immunology of pregnancy is there. Immunology pregnancy is baby is a graft. Baby is a graft. But so the body can initiate a graft versus host reaction. What it will happen? Baby will be about. Because graft versus host reaction happens means graft will be rejected. And the graft is the baby. So baby should not be rejected. For that reason, pregnancy is like immune suppression. Pregnancy is a natural immune suppressed state. So it's a biological or physiological immune suppression so that the graft is not rejected. So baby is allowed to grow. And immunology of delivery, there is heightened immunological reaction, heightened graft versus host reaction, so that it facilitates delivery. So it is because of this immunology of pregnancy. During pregnancy, the patient is like taking an immunosuppressant, like mycophenolate, diethyl fumarate, azathioprine, something as the patient is taking. It is like that. It is like the patient is taking an immunosuppressant because there is a natural immune suppression to prevent the graft rejection. Whereas delivery is double heightened immune response so that the baby is delivered. That's the immunology of delivery. For that reason, the immunological disorders go into relapse during delivery. That is why all these vasculitis, rheumatoid arthritis, most of these disorders which have an inflammatory element, they abort during pregnancy and worsens during postpartum. Reverse, is there any condition which worsens during pregnancy? Some conditions which are very dormant, but they become worse during pregnancy and much worse during delivery. Some conditions. Which one? You told CVT, that is pregnancy, Any
Got it.
procoagulant state, BS delivery, natural to prevent PPH, there is increased fibrinogen. Soon after delivery, blood fibrinogen increases to prevent postpartum hemorrhage. And that fibrinogen clubbed with the dehydration,
Thrombosis.
where people don't give water, that goes into CVT. Or if there is procoagulant factor, that is all the more aggravated. In villages, some people practice depriving the patient from water. The postpartum period, that is some practice in some parts of Tamil Nadu, Karnataka, all those places. So they develop. And if you have procoagulant factor, post-traumatic, post-operative, post-neoplastic, they are all CVTs. So that has nothing to do. So things which worsen during pregnancy. One, hormone-dependent tumor. Tell one hormone induced.
Prolactin.
Yes, pituitary tumors. So cellular tumors. They grow during pregnancy and bleed during delivery. That is called Sheehan syndrome or Simon's disease if it is not related to pregnancy. If it is related to pregnancy, it is called Sheehan syndrome,
Sheehan syndrome.
postpartum pituitary necrosis. So pituitary tumors grow during pregnancy and bleed during delivery. Any other conditions? Meningiomas, arteriovenous malformations. These are the three things. Pituitary tumors, meningiomas, and arteriovenous malformation. They grow, they have hormone role of hormones. They grow during pregnancy and bleed during delivery. So that is what happens. So this person, in the postpartum period, she developed unsteadiness. The unsteadiness, you localize which part of the cerebellum?
Unsteadiness of
Gait abnormality.
Gait abnormality, if any, only gentle gait means anterior part of the paleo-cerebellum.
Yes.
Then patient with truncal gait will be have
railing
neocerebellum.
gait.
Railing gait will be a neocerebellum. Associated with the
reeling gait will be neocerebellum contains part of the homunculus. It is containing head and neck and upper limb. So neocerebellum will only produce upper limb and speech. It will not produce lower limb. So it is archicerebellum or flocculonodular lobe. Archicerebellum or flocculonodular lobe. Hello?
Yes, ma'am. Flocculonodular, hello?
நான் கிளாஸ் எடுத்துட்டு இருக்கேன்.
Hello?
half an hour கழிஞ்சு கூப்பிடட்டா? ஒரு கிளாஸ் எடுத்துட்டு இருக்கேன். சரி. So flocculonodular lobe will produce a reeling type of drunken gait. Paleocerebellum will produce gentle swaying gait. And paleocerebellum only gait ataxia. Whereas flocculonodular lobe will produce gait and nystagmus. Neocerebellum will produce predominant speech, eye signs, upper limbs with mild overflow imbalance. So if imbalance is the first symptom, you are not going to consider neocerebellum. You will consider either paleocerebellum or flocculonodular lobe. If it was gentle swaying, it can be flocculonodular, it can be paleocerebellum. Then sometimes even spinal cord. Spinal cord, what spinocerebellar tracts. You see? So I've got Clark's column. In the spinal cord, Clark's column is there. From the Clark's column, spinocerebellar tracts originate. And these spinocerebellar tracts also produce only ataxia. Gait ataxia, nothing else. No speech, no eye signs, nothing. Can you tell one spinocerebellar ataxia where only the Clark's column degenerates? They have gait ataxia without any other accompaniments of the cerebellum, but they can have posterior column, they can have pyramidal tract. So Clark's column in the
Friedreich's ataxia.
Very good, very good. Very, very good answer. So what does Friedreich's ataxia produce specifically in the MRI?
Friedreich's ataxia produce...
Cerebellum will not show atrophy. So one of the criteria for Friedreich's ataxia is patient is ataxic and you do the MRI, cerebellum is not atrophic. So that is Friedreich's ataxia. So very good. That's a very good answer. So Clark's column degeneration is one cause when there is ataxia without other spinal cord features. But the features of other parts of the cerebellum or brainstem is not there. So that is, so these are the differential diagnoses for a patient with gait ataxia. And of course, you should also consider sensory ataxias, pseudo-ataxias. Sensory ataxia does not worsen in the dark, as I mentioned it somewhere. And there will be a bizarre gait in sensory ataxia, not a swaying or a reeling one. It's a very bizarre gait. Then they will have stick and the stamp. Instead of a broad-based gait in cerebellar disease, it is a stick and the stamp gait in sensory ataxia. They carry a stick to measure the depth of the floor, and still they get lost and they bring down the leg with a stamp. So in sensory ataxia, it's a stick and the stamp gait. Whereas in cerebellar ataxia, it's a broad-based gait. So then when you will check and you'll find posterior column is impaired, other features are not there, and never you get dysarthria, eye signs in sensory ataxia, whereas in cerebellar ataxia, pseudo-ataxia is waddling. So hip abductors weakness, like conditions like CIDP.
Proximal.
So people will tell, I am swaying. We also say swaying, and you look at the MRI and you miss the whole diagnosis. It may be air reflexy element syndrome, radiculoneuropathy. So these are the conditions. So this patient is having a gait ataxia. So all these possibilities are there. We will decide which part after we examine. Second, you said that the unsteady narrow pathways. So narrow pathways, why does the cerebellar ataxia worsen on narrow pathways?
Tandem walking is affected because
of narrow pathways, usually it is cerebellar. Posterior column, it is in the darkness. Waddling gait, that will worsen, ataxia will worsen when you climb up. When you climb up, the hip will dip down, hip dip. Hip on that side will dip. So the unsteadiness worsens while climbing up means it is pseudo-ataxia due to radiculoneuropathy involving the hip abductors. And sensory ataxia means it is worsening in the darkness. Cerebellar ataxia means worsening in the narrow pathways. Why does it worsen in the narrow pathway?
The tandem walking is affected.
Correct. So subtle ataxia, we bring out the subtle ataxia by making the patient do tandem walking. So even subtle ataxia, which is patient says, I am having some imbalance and you are not able to find anything. Then you tell the patient to do tandem. Then you know that is unable to do, and there is a subtle cerebellar involvement. So tandem walking is a test we do to elicit subtle ataxia. So narrow pathways is like doing a tandem walking test. Why that becomes affected? You see cerebellum and basal ganglia. We call it striatopalliidal system and cerebellar system are the movement control system, two systems. Cerebellum controls the rate, range, rhythm, direction, and amplitude. That is precision of a movement, talam of a movement. It is like the music of motor activity. So cerebellum controls rate, range, rhythm, direction, amplitude. So it is the fine coordination of the motor schema. Whereas basal ganglia primarily plays a command and correction. So this fine tuning by rate, range, rhythm, correction is very important. Not when you are walking in your house or walking in a big road, but when you are walking in a narrow pathway, fine coordination of the rate, range, rhythm is important. So that becomes compromise. That is why narrow pathway becomes. So that is pointing to cerebellar involved. So now gait ataxia without so many causes. Now with a patient having more difficulty in narrow pathway, it looks like an involvement of some part of the cerebellum. No? Then unstead is not also loss of, okay, that's okay. Clumsiness in the upper limb is coming now. So that means what? It started somewhere in the paleocerebellum and now spreading to the neocerebellum. Or it can be a superior cerebellar peduncle also. No? So superior cerebellar peduncle,
upper limb ataxia.
How do you differentiate? How do you differentiate?
Superior cerebellar peduncle, the upper limb ataxia will be more, incoordination will be more common. Then if middle cerebellar peduncle affected, spastic.
Between neocerebellum and superior cerebellum. Neocerebellum versus superior cerebellar peduncle, how do you differentiate?
If any dysarthria and eye signs was present, it's
Good. What is the
neocerebellum.
eye sign in neocerebellum?
Gaze evoked nystagmus.
Correct. Gaze evoked nystagmus. So if you find gaze evoked nystagmus in a patient with upper limb incoordination, it is in the cerebellum and not in the peduncle. Second, if a patient with upper limb incoordination is having a staccato speech or a scanning speech, it is in the hemisphere, not in the peduncle. So that is the point to differentiate. So good. So now the upper limb is getting involved. So we think either it is a superior cerebellar peduncle or a neocerebellum until we demonstrate a gaze evoked nystagmus or a cerebellar type of speech. If that is there, then you will have to put in the hemisphere. Otherwise, it may be either in the peduncle or in the neocerebellum. Okay. Next. Also tremors involving both upper limb, which is symmetrical in nature in series. So tremor was the same intention tremor or there was another kind of tremor?
Intentional tremor.
Initially, you told intention tremor, food gets smeared on the face, all those things you told. Is there any other kind of tremor also?
No, ma'am, only intentional tremor. Doing activities only patient will have tremor.
Okay.
Other than
So it's the same. The same thing which produce clumsiness and smearing of food. That you need not mention again, I think. You see, tremor is an interpretation, whereas the smearing of food is a description. So the description is what is needed in the history. So you said patient has got smearing of food while taking and clumsiness at the hand, it is good enough. It says intention tremor. But if the patient had an additional rest tremor and additional tremor during all activities, then you will have to put the lesion in the tremor loop. There is something called tremor loop that goes to the peduncle only, olivodendate or rubro-thalamocortical pathway. So if there are multiple types of tremor in the same patient, then you will implicate the tremor loop. You have got wing beating tremor, you have got horizontal action tremor, essential tremor, rest tremor, intention tremor. So all tremors are there means the pathology you have to put in tremor loop. That is in the peduncle only, not in the hemisphere. So like that. But if it is only one tremor, there is no reason to say again tremor. You already described that. Okay. Urinary incontinence. That sentence also I want to correct. You said that urinary incontinence in the form of increased urinary frequency, urgency, nocturia, income. In that, if you write that sentence, you mean to say that frequency is incontinence, urgency is incontinence, nocturia is incontinence, incomplete bladder emptying. It's not, no. So this sentence means all these things are synonymous. It is not. So urinary incontinence can be with awareness or without awareness. So what you mean by incontinence? You have a social incontinence. That happens in patients with frontal lobe disease. So it's a learned social behavior that you can urinate only in certain places. So that is lost in frontal lobe disease. So patient will pass urine and do not regret about that. So they simply pass, you ask them. Sometimes they will say, it is not me, it is cat, dog, child, something like that, and all they will tell. Or sometimes they will tell, it is my house, I will pass. Who are you to question? So that is loss of learned social sense. That's a frontal lobe incontinence. Otherwise, you have got incontinence in continuous dribbling incontinence in LM and bladder.
Overflow incontinence.
That is autonomous bladder.
Autonomous bladder.
So what is the feature? What are all the features of autonomous bladder? So this person is obviously not having a frontal bladder. Is she aware? Is she sad or is she happy that she is incontinent? Is she?
No. Yes, ma'am. He is aware.
She is aware and she is sad, no?
Yes, ma'am. Patient was aware while incontinent.
So that is not a frontal incontinence.
Frontal.
What are the features of an autonomous bladder?
Patient will have walking and leaking. Overflow incontinence will be present.
Describe the autonomous bladder.
Patient autonomous bladder will be the detrusor muscle. The fullness of the bladder will be more. The patient will not recognize that fullness. Then after that overflow, the incontinence will be present. This detrusor and the sphincter dyssynergia will be present.
So
Any
when this
conus
patient is
involvement.
coming with incontinence, will you be able to type it only after urodynamic studies to show that detrusor dysfunction
No,
is?
ma'am. Patient will have a walking and leaking feature will be there. Dribbling of urine and stream of urine will be, and incomplete evacuation of urine will be present.
No. You see, autonomous is that's why you are confused all these terms. It is not at all correct. You see, you either tell patient has incontinence with lack of social sense. So I think my patient's frontal lobe is involved. Patient is having the sensation of bladder fullness. She can voluntarily initiate micturition. She can completely empty the bladder. Only thing, she passes urine in wrong places and is happy about that, not sad about that. That is frontal bladder. Second incontinent bladder is autonomous bladder, where only the bladder wall centers are active. Sacral center is also destroyed. That is autonomous bladder. Autonomous bladder patient will be not having any bladder sensation. Unlike a frontal bladder, they have bladder sensation. Autonomous bladder, they do not know filling, they do not appreciate pain. When the urine amount accumulated is beyond a limit, pain and discomfort will come. So they neither feel full nor feel pain and discomfort. The bladder goes on expanding. Why is the bladder going on expanding?
Sacral parasympathetic is affected.
Bladder goes on expanding because only the bladder wall centers are there. You have got beta adrenergic receptors in the body of the bladder and alpha adrenergic receptors in the sphincters. Same or adrenergic. So beta adrenergic is beta agonist. They do relaxation. Alpha agonist, they do contraction. So same adrenergic receptors will relax the bladder and contract the sphincter. So only bladder wall receptors are there. The bladder wall receptors are beta adrenergic in the body of the bladder. They are sympathetic, not parasympathetic. They are sympathetic, beta adrenergic in the body of the bladder and alpha adrenergic in the sphincters. So bladder will expand and sphincter will close. Normally what happens when the amount of urine stored in the bladder becomes about 300 to 400 ml, the bladder wall receptors will send information to the sacral center. So sacral center will tell, okay, store little more. So it will store some 500 to 600 ml. And after 500 to 600 ml, through the spinothalamic and proprioceptive information, it will go to the brainstem centers. And then what you want to tell means you tell. If you are wanting to tell, you tell. Yes, it should be very clear. Because you are confused, that's why I am telling. So if you want to tell, you can tell. You tell.
After that,
It's your discussion.
Initially the patient will have to 150 ml of urine have to be filled. After that, the sensation went to sacral segment. Sacral segment, the stretch reflector will be activated, and then to accumulate more amount of urine. After that 400 ml was reached, then
See,
the
we are
symptoms
clinicians now. We are clinicians now. So you should describe the clinical symptoms. Something you are telling. So I will tell you clearly so that you register it. Because you want to tell. That's why I told you to tell. Now you listen what I am telling. So and register. Okay. You see, bladder wall receptors. Did you understand that concept? Bladder wall has adrenergic sympathetic receptors. They are beta receptors in the body of the bladder and alpha receptors in the sphincter. When urine just flows into the bladder, up to that it is like a balloon where you are putting some water or air. So initial part, nothing, no neural mechanisms are happening. Only the mechanical property. All of us know that when you release a balloon, at the end some air will remain. Because of that, it is no more the old balloon which was shrunk. That is retaining some air based on its wall capacity. Only the wall capacity, no expansile property. So like that, beta adrenergic receptors allow the bladder to expand, and alpha receptors allow the bladder to store without any neural mechanisms. That is up to about 300 ml. So now after that, bladder will send its afferents. Oh, this has collected beyond it, I have no control. So I want help from the higher centers. So the information will go to the sacral center. Sacral center has got a higher capacity of storage. It is by neural mechanism. Only coming to the sacral center, neural mechanisms are coming. Their parasympathetic is for storage and sympathetic is for emptying. So both are there. So if you are going to catch a bus and in the bus you'll be there for 4 or 5 hours, you want to empty your bladder, you can go to the toilet and empty using your sacral center. Or you say you are in the classroom, I want to store. So based on that, either the parasympathetic or sympathetic is more dominant, either store or empty when it is beyond that bladder wall capacity. And sacral center, beyond 600 ml, sacral center has no capacity. So sacral center will send information to the brainstem centers and basal ganglia. They are called Barrington center. So that has got a little more higher level. Up to 1 liter or so it can store. And beyond that, cortex. Cortex can store up to 1.5 to 2 liters. So store means what? It will facilitate sympathetic and inhibit. It will facilitate parasympathetic and inhibit sympathetic. So you keep on storing. That is by higher cortical mechanisms. There are functional loops for bladder control. They are called Bradley's loops. Bradley's loop 1, 2, 3, 4.
Okay.
So various loops are there. They have different bladder capacity. So autonomous bladder is a second incontinent bladder, other end of the spinal cord. So here, because the sacral center is not there, only bladder wall center is there. So bladder wall center gives information to the sacral center. It is not there to receive the information. So it keeps on expanding. So bladder keeps on expanding to the maximum capacity. So autonomous bladder is a large bladder. It's a very large bladder because the beta receptors are going on expanding unmodulated by the sacral center. So it's a very large bladder and the sphincters are closed. So it doesn't open. Even though the urine is going on gathering, sphincter doesn't open. Because alpha receptors of the sphincter keep closing, beta receptors of the body keeps expanding. So huge bladder is coming. Because it is not connected to any tracts through sacral center. Patient does not appreciate pain. Patient does not appreciate fullness. Instead, he may feel a mass in the abdomen. He may feel that my abdomen is bloated and there is some swelling, but he will never feel pain or discomfort. And after about 1.5 liters to 2 liters are stored, the weight of the urine will open the internal sphincter and dribble the urine out. So the rate of secretion of urine is about 0.3 ml per minute. So that extra urine dribbles out. So an autonomous bladder is a large bladder. Patient has no sensation of fullness or pain. He has no control over micturition and he is continuously dribbling. So now tell me the features of autonomous bladder.
Patient doesn't have the pain during the
First,
fullness of
tell
bladder.
large bladder. You see, that's
Large.
the most important thing now. Remember all these points. Large bladder.
Large bladder, then patient pain will not, during the large bladder, the pain is not present, followed by
No
patient
pain or
have
no fullness and continuously dribbling.
dribbling of urine.
Continuously dribbling.
Continuous dribbling of urine.
And 1 minute, I'll come. So autonomous bladder, you understood. No. Next is the automatic bladder. So these are the two incontinent bladders. Only frontal bladder and autonomous bladder. Other bladders are not called incontinent bladder. No.
Okay.
What are the features of an automatic bladder?
Patient have increased frequency of urination, urgency, nocturia, spasticity of the bladder.
Just like I told you, what is autonomous bladder? You describe.
Patient's bladder was contracted small in amount. And
that means you have to go to the urologist, no? You have to do urodynamic study and see whether the bladder is contracted or not. So clinician tell me what is automatic bladder. So automatic bladder means
So,
sacral center is there. Autonomous bladder, sacral center is also not there. Only the bladder wall receptors are there. Whereas automatic bladder, sacral center is there. So bladder, body of the bladder, when it gathers some 400 ml of urine, it will convey the information to the sacral center. So sacral center is receptive. That is the situation of automatic bladder. So sacral center has got a higher capacity.
okay.
So to control. So it will allow the bladder to store about 500 to 600 ml. So bladder wall receptors are sensing that urine is accumulating and that message has come. So now I have to allow proper storage without reflex or without reflex will produce kidney damage, residual urine will produce renal calculi and infection. So without either residual urine or reflex, it will store up to 600 ml. So at 600 ml, what it will do? It will ask the Barrington Center.
Okay.
I told you, no, it will ask the Barrington Center. Then you would find that there is a transverse cord section. So it cannot communicate with the Barrington Center. So the input from the sacral centers will go up. It is stopped there by the transection of the cord. So it comes back. I cannot contact the Chief Minister or Prime Minister. So I am coming back. So it comes back and empties the bladder. That is why it is called automatic bladder. So automatic bladder is not a continuous dribbling bladder. It is not a continuously incontinent bladder. Allah. That is why it is not coming under incontinent bladder. So automatic bladder stores up to 600 ml. It periodically empties automatically. That is why it is called automatic bladder. It is not by will. Now, by will, you cannot initiate maturation. By will, you cannot stop maturation. Automatically, it empties. When 600 ml is gathering, it will try to go up. It is unable to go up. It comes back and empties the bladder. So, periodically, the bladder will empty. Patient may partially have bladder sensation or totally not have bladder sensation, depending on the degree of spinal cord damage. If it is a mild damage, patient will have partial sensations. If it's a partial transection of the cord, they will have partial sensation. If it's a complete transection of the cord, they will not have any sensation. So in the pre-voiding phase, urine can store up to 600 ml. Bladder sensations are either totally lost or partially present. And at the end of 600 ml, automatically the bladder empties. And it is not a dribbling bladder like an autonomous bladder. Autonomous bladder is a dribbling bladder, whereas this will periodically empty good amount of urine. 500 to 600 ml, it will empty. And at the end of empty, there will be detrus or intersphincter descent. There is a residual urine. So that will result in post-voiding dribbling. Whereas autonomous bladder is continuously dribbling only. There is no question of good volume of urine emptying. There is a continuous dribble. Whereas in automatic bladder, there is automatic emptying at short intervals when the 600 ml has accumulated without patient's control. So describe the automatic bladder means the storage capacity is 500 to 600 ml. Pre-voiding sensations may be partially present or absent, and there is no continuous dribbling. There is automatic empty when the urine amount is about 600, and there is good amount of residual urine that results in post-voiding dribbling. Here the lesion is above the sacral center. Sacral center is there. It is disconnected from the higher centers. Then you go to the spinal cord, you have got other types of bladder, sensory denervated bladder, where the posterior column like tabes dorsalis or pseudo-tabes or diabetes, there is a painless retention, but they can empty by voluntary control. That is painless retention, sensory denervated bladder. Common condition is diabetes. And you have got a motor denervated bladder where there is a painful retention, where the efferent limb is affected, like acute Guillain-Barré syndrome, acute poliomyelitis. There is a brief period of bladder painful retention, which they will come out of that. Then you have got a precipitancy and hesitancy.
And
What do you understand by the term precipitancy? Precipitancy, hesitancy, frequency, urgency. So many things you have to explain each term.
Urgent.
What is precipitancy? You are getting normal bladder sensation. You want to go to the toilet. You have the normal walking speed. You are able to walk. But before you reach the toilet, you pass urine. That is called precipitancy. Everything is normal. You are not affected by a fracture or a paraplegia or anything. But before you reach the toilet, you pass urine. That can happen with irritative lesions of the urinary tract, like urinary infection. You can have it with prostatism. Otherwise, neurologically, if these two things are not there, neurologically, you have got facilitatory fiber and inhibitory fiber. Facilitation for emptying goes through sympathetic. Facilitation for storage goes through parasympathetic. So if the facilitatory fiber is facilitated or disinhibited, and inhibitory fiber is impaired, partial bladders. So inhibitory fiber is damaged, whereas facilitatory fiber is normal. Then you will get precipitancy. Reverse, you have the facilitatory fiber is damaged and inhibitory fiber is preserved. You get hesitancy. So you get the bladder sensation, you go to the toilet, you have to strain to initiate micturition. That is called hesitancy. They are all partial spinal bladders. When there is a facilitatory fiber involvement, you get hesitancy. When the inhibitory fiber is involved, you get precipitancy. And you have said frequency. What does frequency indicate?
Patient, the time of micturition was increased. The increased number of micturition.
So what is the commonest cause for frequency micturition?
UTI.
Yes.
Urinary tract infection.
So when there is a frequency, you will ask, is the frequency associated with the large amount of urine, or is the frequency associated with small amount of urine or normal amount of urine? So if it is a large amount of urine, it is diabetes mellitus. So you get frequency of micturition because of increased secretion of urine. That happens in diabetes mellitus. And also it happens in diabetes insipidus. There also large amount of urine is secreted. Whereas if you have frequency with very less amount of urine, that is what you told, cystitis, intravesical calculus, bladder tumors, those conditions, frequency due to irritation. That is frequency with smaller amount of urine. And frequency without irritation, urgency is pain, urgency is irritation. So frequency without urgency, that indicates storage failure. Storage failure. So supposing you have got a partial autonomic dysfunction, the bladder is not able to store, or chronic contracted bladders, chronic catheterized bladder. So intravesical tumors and storage failure due to autonomic dysfunctions. So these situations, the bladder will store less, but there will be no urge, there will be no pain. Urgency is the term used when there is associated sensory symptoms like pain. So then nocturia. What does nocturia indicate? Nocturia also?
Patients will pass more amount of urine during night time. Patient was passing more amount of urine. Increased frequency of urine in the night time.